Of course, it's the basic question, why Irapum? It was an idea that was formed a couple of years ago when I saw that a lot of results showing that regional anesthesia wasn't always making a big difference or having a positive influence like we thought. I saw that a lot of regional anesthesia papers didn't really show a difference in outcome. And I think it's because people are too focused on the right block, not looking at the whole patient. So looking at all the different steps, a little bit like ERAS, makes much more sense. And we looked at all the different parts where we could enhance the whole process of surgery, looking at our regional anesthesia, like optimizing preoperatively, identifying pain catastrophizers, not giving too much sedation, also looking at multimodal approaches postoperatively, like physiotherapy, yoga, also looking at who needs a block more, because like trauma patients actually need blocks more because of the chance of opioid addiction. So we looked for different specialists there, and we looked over the pond. A very good friend of mine, Aaron Burke, is in there, and Atmayatu Dungle, who is also a chronic pain specialist. So I think having 4 different people looking at all the different aspects makes a better approach than just doing a block and not caring about the rest. This question is actually not so easy, because we put a lot of different points in there, just because those are the points which are mainly overlooked in most regional anesthesia. If I were to choose one, I think it's the one who deserves to get a block. And I will give an explanation. Usually, a lot of people invest blocks for ambulatory surgery or simple, easy things like shoulder surgery, which is all great, but probably doesn't make a huge difference in outcome except better pain relief. However, trauma patients who might have repeat operations and might end up in the intensive care ward with prolonged exposure to opioids, those are usually the ones overlooked for blocks. Why? Because we're afraid of compartment syndrome, we're afraid of informed consents, we're afraid of neural damage if a patient has already some axonal injury after a trauma, and that's why we don't usually do it. And I think those patients are the ones where we probably can show that regional anesthesia has an impact on a prolonged outcome, like a better outcome, less opioid addiction, and even better functionality. And it's because a lot of people do not do it in those patients. We do a disservice to our regional community and our outcome parameters, and also to our patients. Again, not the easiest question, because most of the parts, again, are not that easily implemented, because otherwise everybody would do them. In my opinion, probably the easiest one is stop over sedating and use the different applications which you have nowadays. It's so easy. You have virtual reality systems, but even something as easy as music. You have AirPods. You can ask your patients to bring them. I think that already makes a huge difference, again, because over sedation, especially when using benzodiazepines, probably has an influence in our overall outcome. And I've seen a lot of sedations with regional anesthesia being done in hospitals where it's almost akin to a general anesthesia together with a block, which doesn't mean that it's per se not a good practice, but it's not needed when the block is enough. It's different when you need, of course, general anesthesia on top of a block. And I think that's really easy to implement. You buy a couple of headphones or earpods, you put that in an information brochure, you invest in like one virtual reality system, and you expose your patients to it. You will see that makes a huge difference already.